ABO blood group systems. Blood group erythrocyte contain agglutinogen or antigen. Plasma contains agglutinin or antibody. The ABO blood group can be classified into four major blood groups, that is group A, blood group B, blood group AB, or blood group O. Blood group A contains antigen A and antibody B, whereas blood group B contains antigen B, antibody A. Whereas blood group AB contains both the antigens, it has no antibodies, whereas the blood group O contains no antigens but it has antibody, both anti-A and anti-B. Lance-Stenius law states that if a particular agglutinogen or antigen is present in the RBCs, the corresponding agglutinin, that is the antibody, must be absent in the plasma. The second law states that if a particular agglutinogen is absent in the RBC, the corresponding agglutinin must be present in the plasma. The second law is not applicable to the Rh, M and N blood groups because they do not have naturally occurring antibodies. Cross-matching. In clinics, cross-matching is always done before blood transfusion. There are two types of cross-matching, that is major or direct or minor or indirect cross-matching. In direct cross-matching, here the donor's RBCs are mixed with the recipient's plasma and checked for agglutination. The donor's plasma get diluted with the recipient's plasma so that agglutination of recipient's RBC occur rarely. And in indirect cross-matching, here the donor's plasma is reacted with the recipient's RBC and checked for agglutination. If agglutination occurs during either of both the tests, the blood from that person is not used for Rh blood group system. Rh factor is an antigen present in the RBC. This system primarily comprises C, D and E antigens. D is the most antigenic compound, and the term Rh positive generally means that individual has the agglutinogen D. The antibody in this system is called as anti-D and is produced only when Rh negative individual receives the D antigen. The antibodies are IgG variety. Rh factor is inherited as a dominant factor. Hemolytic disease of newborn. When Rh negative mother carries Rh positive fetus, small amount of blood leak into the maternal circulation at the time of delivery. During postpartum period, mother develops Rh antibody in her blood. When mother conceives for the second time, if the fetus happens to be Rh positive again, the Rh antibody from mother's blood crosses the placental barrier and enters the fetal blood, and only Rh antigen cannot cross the placental barrier, whereas Rh antibody can cross it. The Rh antibodies which enter the fetus cause agglutination of fetal RBCs resulting in hemolysis. The changes in the fetus are termed as hemolytic disease. There are various forms of hemolytic disease of newborn. Erythroblastosis fetalis. The disease is also called as icterus gravis neonatorum. The infant jaundiced due to the excessive destruction of RBC. Due to severe hemolysis, anemia develops and fetal body tries to compensate. As a result, large number of premature red cells, that is erythroblast, appear in the peripheral circulation of the fetus. Hydrus fetalis. If hemolysis is more severe, death of fetus occurs in the uterus and may develop severe jaundice, anemia and edema. Kernicterus. It is a condition which develops when bilirubin deposition occurs in basal ganglia of brain, as blood-brain barrier is not developed in fetus and newborn infants, which produces abnormalities in the functions of basal ganglia. Treatment of hemolytic disease of newborn. One thing is phototherapy. Neonatal jaundice can be treated by phototherapy. That is, bilirubin is photoisomerized to limirubin, which can be excreted in the bile. Drugs like phenobarbital and exchange blood transfusion soon after birth, that is, to replace neonates the blood with Rh negative blood. Prevention of STN is administration of anti-Rh antibodies, that is anti-D antibodies, soon after the childbirth if the Rh negative mother gives birth to Rh positive child. It, it is also administered to expectant mother starting at the 28th to 30th week of gestation. Blood transfusion. Some of the indications of blood transfusion are blood loss, blood disorders, blood diseases, poisoning, and acute infections and shock. Some of the complications of blood transfusion are which are due to the mismatched transfusion where antibodies in the recipient serum attach to the antigens of the donor's RBC. This antigen antibody reaction leads to agglutination, that is, they form the clumps. The RBC is first agglutinated and then undergo hemolysis. The clumps of cells may block smaller blood vessels in the coronary, pulmonary, and renal circulation. This may result in shock. The hemolyzed RBCs causes increase in the release of hemoglobin, which gets metabolized to bilirubin and may lead to jaundice. If the amount of hemoglobin in the renal tubules is sufficiently high, the kidney failure can develop. Some of the complications which are not due to the mismatched blood transfusion. There can be excess volume transfusion which can lead to hypervolemia, and as stored blood cells lose potassium to the external plasma, hyperkalemia results. Or blood is stored using citrates and transfused blood contains enough citrates. With a massive transfusion of citrated blood, citrate removes calcium ions of recipient blood. This results in hypocalcemia. There can be chances of hemosiderosis which occurs because of the deposition of excess iron. Pyrogenic reactions like fever can occur, allergic reactions and shock can occur because of the released cytokines, and can be transmission of diseases like AIDS, malaria, syphilis when you are doing blood transfusion. So hazards of blood transfusion can be due to the mismatched blood transfusion and due to the blood transfusion. Because of the mismatched blood transfusion, there can be immediate effect, delayed effect. Immediate effects are hemolysis, shock, and renal failure, whereas delayed effect is jaundice. Due to the matched blood transfusion, there can be again immediate manifestation or delayed manifestations. Immediate manifestations or complications are pyrogen reaction, shock, coronary overload, hyperkalemia, and hypokalemia, whereas delayed complications are transmission of the diseases and hemosiderosis. Blood storage. For better long-term preservation of blood and for transfusion purposes, citrate is used in combination with dextrose in following forms. Acid citrate dextrose, that is ACD solution, trisodium citrate, citric acid, and dextrose. The pH is 5.4, where you have to add 10 volumes of blood to 1.5 volumes of the solution. This form of the blood can be stored up to 21 days. Citrate phosphate dextrose adenine, that is CPDA solution, where you have sodium citrate, citric acid, dextrose, and adenine. pH is between 5.6 to 5.8. You have to add 7 volumes of blood to 1 volume of solution. This form of blood can be stored up to 35 days. And dextrose acts by liberating lactic acid, which by decreasing pH helps in survival of RBCs both in vitro and in vivo, providing substrate for the metabolism which is required even at 4 degrees Celsius and thus helps the survival of the cells. So that is the function of dextrose. Changes which occur in the stored blood. Blood stored in the blood bank suffers some changes. There is a decrease in 2,3-DPG, so there is an increase in the affinity of hemoglobin to oxygen, increase in potassium concentration in plasma, so there could be a chance of hyperkalemia. There is increase in the concentration of sodium in the RBC. decreased viability of RBC so that they cannot work for longer time due to the decreased ATP in them. There might be decrease in the platelet count, and there